Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr. Sreenivas Concepts. This is Dr. Sreenivas, neurophysician from Rajahmundry, Andhra Pradesh, India. My email is sreeklpm@gmail.com. I am also the medical author of the two books Focused Neurology and Exam Oriented Clinical Neurology. Today we are going to talk about headache part 2, that is migraine and primary headache. So today we are going to talk about migraine and primary headache. There are going to be 50 episodes of Prime Neurology, and if one listens to all these 50 episodes of Prime Neurology, one would have acquired a good knowledge of neurology. Right now we are on primary neurology part 19, headache part 2. So we are going to discuss migraine and primary headache. Primary headache. 90% of all headaches are primary headaches. Primary headaches usually start when people are between 20 and 40 years old. The primary headaches are migraine, which is unilateral, pulsating, accompanied by nausea or vomiting. Tension type headache, which is bilateral, band-like pressure on both sides of the head, usually without nausea or vomiting. Then we have trigeminal autonomic aphalgias and other primary headaches. So first let's discuss migraine. They are recurrent headache attacks of moderate to severe pain intensity with a duration of 4 to 7 hours with normal physical examination and no other reasonable cause for the headache. Easy to diagnose migraine is by the rule 4-3-2-1. 4-3-2-1 rule. What are these 4-3-2-1? First is 4 and 3. Duration is 4 hours to 3 days. That is 72 hours. The second point is 2. At least 2 of the following features: unilateral pain, throbbing pain, aggravation by movement, moderate or severe intensity. Finally 1 plus at least 1 of the following features: nausea bar vomiting, photophobia and phonophobia. So to diagnose migraine, we have to remember this rule of 4-3-2-1. A migraine attack has 4 phases. One is the premonitory or prodrome. There will be mood changes, neck discomfort lasting from few hours to days. Then comes the phase of aura, seen in 20 to 25% of migraine patients. They'll have visual disturbances, flashing lights or zigzag lines moving across the visual fields, scintillating scotoma. Third is the headache phase per se, pain with its associated features such as nausea, photophobia, phonophobia or allodynia. And finally we have the postdrome phase where they'll have tiredness and concentration is impaired. Chronic migraine. If the headache suggestive of migraine for more than 15 days per month, for more than 3 months, then we have to consider chronic migraine. How do we differentiate migraine versus tension type headache? Sometimes it becomes very difficult to differentiate whether the patient is having migraine or tension type headache. So how do we differentiate? Migraine at its most basic level is headache with associated features, and tension type headache is headache that is featureless. Most patients with disabling headache probably have migraine. What are the migraine triggers? Glare and bright lights, sounds, hunger, let down from stress, hormonal fluctuations during menses, lack or excessive sleep, alcohol, chemical stimulants like nitrates. Pathogenesis. The sensory sensitivity that is characteristic of migraine is probably due to dysfunction of monoaminergic sensory control systems located in the brainstem and hypothalamus. Treatment. We have non-pharmacologic management and we have pharmacologic management. Pharmacological management includes acute attack therapies for migraine and preventive therapies for migraine. In general, a preventive medication to be considered in patients with 4 or more attacks a month. So first let's see the non-pharmacologic management. They should have a healthy diet, regular exercise, that is 30 minutes per day. 30 minutes per day. So if you do it for 7 days, it will be 210 minutes per day. American Heart Association itself says only 150 minutes per week. And therefore, if we do exercise for just half an hour a day, we'll have good results. The exercise is not only good for your physical well-being but also mental well-being. When we exercise, body starts producing enkephalins, endorphins, which relieve pain. They are known as happy hormones. So regular exercise is one of the important components of non-pharmacologic management. Regular sleep patterns. Too less a sleep or too much of a sleep also causes headache. The normal sleep duration suggested is 8 hours per day. 7 to 8 hours per day. That means 1/3 of the time we have to spend on sleep. Avoidance of excess caffeine and alcohol. Avoidance of stress. Patients with migraine do not encounter more stress than headache-free individuals. Over responsiveness to changes in stress appears to be the issue. The pharmacologic management. As I said, the pharmacologic management consists of two subcategories. One, treatment of acute attack per se, and then prophylactic treatment, that is prevention. So acute attack therapies for migraine include non-steroidal anti-inflammatory drugs like NSAIDs, example naproxen, 5-HT1B1D receptor agonists like triptans, CGRP receptor antagonists like GPANs, or 5-HT1F receptor agonists like ditans. We also give dopamine receptor antagonists. Why? Because drug absorption is impaired during migraine because of reduced gastrointestinal motility. In addition, they decrease nausea and vomiting and restore normal gastric motility. So generally we give dopamine receptor antagonists also like metoclopramide and domperidone. So what is the proposed treatment algorithm for the clinical management of migraine? Non-steroidal anti-inflammatory drugs should be considered first-line medications for the treatment of migraine attacks. Patients in whom NSAIDs provide no or inadequate pain relief should be offered an oral triptan. If an oral triptan provides no pain relief, other triptan should be offered. Combination therapy with naproxen sodium should be offered to patients who have inadequate pain relief with triptan. Ideally, clinicians should first offer subcutaneous sumatriptan when a patient has an inadequate pain relief with all oral medications. However, subcutaneous sumatriptan may be tried at an earlier stage if oral triptans cannot be ingested because of vomiting or if headache intensity peaks rapidly. Ditans and G-pantons may be considered for patients in whom NSAIDs and all available triptans are ineffective, have unacceptable side effect profiles, or are contraindicated. The decision about when to substitute a triptan with a G-pant or a ditan should be made in accordance with local practice guidelines. Antiemetic agents may be offered as an adjunctive therapy in patients with attacks accompanied by nausea or vomiting. So this is the way we go. The first line treatment is NSAID. We have to add antiemetic if there is nausea or vomiting. If NSAID is contraindicated, we have to give acetaminophen. So we continue with NSAID, but if there are more than 3 consecutive attacks with no or insufficient response to one NSAID, then we have to give triptan. If monotherapy is insufficient, add naproxen. After adding triptan, if there are more than 3 consecutive attacks with no or insufficient response to all available triptans plus naproxen, we add ditan or G-pant. So this is how we continue. This is the algorithm. So after adding ditan or G-pant, then we see the response. So now till now we have discussed that treatment, acute treatment per se. What is the pharmacologic management, that is preventive treatment for migraine? So as I said, migraine treatment consists of treatment of acute attack per se and prophylactic or preventive treatment. So what are all the drugs available for preventive treatment for migraine? One is the beta blocker, example propranolol. Second is the antidepressant amitriptyline. This is one of my favorite drugs because most of the patients with headache are either depressed or they overtly react to depression. So I always add antidepressant to a person who's got migraine. Anticonvulsants, example topiramate. Calcium channel blockers, example flunarizine. Monoclonal antibodies against CGRP or its receptor, example eptinezumab, or Botox, approved only for chronic headache, chronic pain. So preventive treatment of migraine. Initiation of preventive treatment should in general be considered for patients who have at least 2 migraine days per month and are adversely affected despite therapy. Preventive treatment, at least 2 migraine days per month and adverse effect despite therapy for migraine. So initiate preventive treatment. So it could be antihypertensives like atenolol, bisoprolol, candesartan, metoprolol, nadolol, propranolol, or anticonvulsants like sodium valproate, topiramate, antidepressant like amitriptyline, calcium channel blockers like flunarizine, or monoclonal antibodies against CGRP or its receptor like erinumab, fremanezumab, galcanezumab, eptinezumab, or onabotulinum toxin A, approved only for chronic migraine. So far we've discussed migraine. Now let's talk about tension type headache. Tension type headache, it is commonly used to describe a chronic head pain syndrome characterized by bilateral tight band-like discomfort. The pain builds slowly, fluctuates in severity and may persist more or less continuously for many days. The headache may be episodic or chronic, example present for more than 15 days per month. Note, the presence of associated features is migraine and the absence of associated features tension type headache is highly recommended. Pain of tension type headache we give NSAIDs. For chronic tension type headache we give amitriptyline. So we've discussed migraine, tension type headache. Now we'll talk about trigeminal autonomic cephalgias including cluster headache. Trigeminal autonomic cephalgias are characterized by relatively short lasting attacks of head pain associated with lateralized cranial and autonomic symptoms such as lacrimation, conjunctival injection, nasal congestion or oral fullness. The trigeminal autonomic cephalgias include cluster headache, paroxysmal hemicrania, SUNCT, short-lasting unilateral neuralgiform headache attacks with conjunctival injection and tearing, or SUNA, short-lasting unilateral neuralgiform headache attacks with cranial autonomic symptoms. Let's talk about cluster headache. Cluster headache. A core feature of cluster headache is periodicity. That means if it occurs at 6 p.m. today, the next day also it occurs at 6 p.m. The day after the next day also it occurs at 6 p.m. Almost every day it occurs at the same time. So the core feature of cluster headache is periodicity. Patients with cluster headaches tend to move about during attacks, unlike migrainists who prefer to remain motionless during attacks. So cluster headache patients, they keep moving about, then only the pain comes down, whereas migraine patients, they quietly lie down, then only the pain comes down. In cluster headache, males are more affected. Alcohol may trigger onset of attacks, may be nocturnal. Attack frequency is about 1 to 2 per day and lasts for about 15 minutes to 3 hours. It is associated with ipsilateral symptoms of cranial parasympathetic autonomic activation like lacrimation. The phenomenon of unilateral photophobia or phonophobia is characteristic of trigeminal autonomic cephalgias. So what is the treatment? The acute treatment for cluster headache is oxygen inhalation. Oxygen inhalation. This should be given as 100% oxygen at 10 to 12 liters per minute for 15 to 20 minutes. Sumatriptan 6 mg subcutaneous can be tried. The preventive treatments include short-term prevention, prednisone 1 mg per kg up to 60 mg QD, tapering over 21 days. Long-term prevention includes verapamil 160 to 960 mg per day. Now we'll talk about paroxysmal hemicrania. The essential features of paroxysmal hemicrania are unilateral, very severe pain, short lasting attacks 2 to 45 minutes, very frequent attacks usually more than 5 per day, marked autonomic features, ipsilateral to the pain, rapid course less than 72 hours, and most important, excellent response to indomethacin. Now let's talk about SUNCT and SUNA. SUNCT is a rare primary headache syndrome characterized by severe unilateral orbital or temporal pain that is stabbing or throbbing in nature. Diagnosis requires at least 20 attacks lasting for 5 to 240 seconds. Ipsilateral conjunctival injection and lacrimation should be present. In some patients, conjunctival injection and lacrimation is missing and the diagnosis of SUNA can be made. The characteristics that lead to a suspected diagnosis of SUNCT are the cutaneous triggers. Most SUNCT attacks have cutaneous triggers such as touching the face or the scalp, washing, shaving, eating, brushing the teeth, talking and coughing. The abortive treatment includes lidocaine and the preventive treatment includes lamotrigine. So what are the clinical features of trigeminal autonomic cephalgia? That is cluster headache, paroxysmal hemicrania, SUNCT or SUNA. Gender: in cluster headache, males are affected more than females, whereas in paroxysmal hemicrania, females and males are equal. SUNCT, SUNA are also almost equal. When we talk about pain, in cluster headache, it is a stabbing and boring type of pain, excruciating, and it is in the orbit and temple. Whereas if it is paroxysmal hemicrania, it is throbbing, boring, stabbing, excruciating, orbit and temporal. In SUNCT and SUNA, it is burning, stabbing, sharp, severe to excruciating, again periorbital. The very important difference comes in the attack frequency and the duration of attack. If we see the attack frequency, cluster headache is only 1 per alternate day or 8 per day. Whereas here the attack frequency increases 1 to 20 per day, that is more than 5 per day for more than half of the time. In SUNCT and SUNA, the attack frequency increases manyfold. It is 3 to 200 per day. Again, another important differentiating point is the duration of the attack. Here the attack lasts quite a long time, 15 to 180 minutes. Here it is moderate, 2 to 30 minutes. But here it is very less, only 5 to 240 seconds. When we talk about the autonomic features, the cluster headache has autonomic features, paroxysmal hemicrania has autonomic features, SUNCT and SUNA, yes, but prominent conjunctival injection and lacrimation. The migraneous features are present in all the three, and the alcoholic trigger is seen only in cluster headache. The cutaneous triggers are seen only in SUNCT and SUNA. The indomethacin effect is seen only in paroxysmal hemicrania. The abortive treatment of cluster headache includes sumatriptan injection or nasal spray, but very important is oxygen. For paroxysmal hemicrania, there is no effective treatment. For SUNCT or SUNA, it is lidocaine IV. Prophylactic treatment for cluster headache include verapamil, methotrexate, lithium. For paroxysmal hemicrania, it is indomethacin. For SUNCT or SUNA, it is lamotrigine, topiramate or gabapentin. So this is about trigeminal autonomic cephalgias. Now let's talk about other primary headaches. The other primary headaches are about approximately 10 in number. 1. The primary cough headache. 2. Primary exercise headache. 3. Primary headache associated with sexual activity. 4. Primary thunderclap headache. 5. Cold stimulus effect. 6. External pressure headache. 7. Primary stabbing headache. 8. Nummular headache. 9th. Hypnic headache. 10th. New daily persistent headache. These headaches, as the name suggests, are self-explanatory. But very important feature is that most of these headaches are responsive to indomethacin. So these are all the wonderful concepts of primary headache and migraine. I hope you have enjoyed listening to these concepts. The other important concepts of clinical neurology I have put in a book called Exam Oriented Clinical Neurology, written by me, Dr.Sreenivas, published by White Army Publication. This book will be very useful for students appearing for clinical neurology exams, and if interested, this book could be purchased. The other book I've written is Focused Neurology. It contains all the essential theoretical points of neurology in a question and answer format. So this book, Focused Neurology, is written by me, Dr. Sreenivas, published by CBS Publishers and Distributors. This book will be very useful for exams, for students preparing for oral exams. This book is available online from all leading booksellers, including Amazon. So if interested, this book could be purchased. As I said in the beginning of this lecture, there are 50 episodes of Prime Neurology, and if one listens to all these 50 episodes of Prime Neurology, one would have acquired a good knowledge of neurology. Just now we have finished 19th episode of Prime Neurology, discussing the primary headache and migraine. There are many more episodes to come. So I suggest to listen to all these 50 episodes of Prime Neurology to acquire a good knowledge of neurology. If you have enjoyed this video concepts, please like and subscribe to my YouTube channel, Dr. Sreenivas Concepts, which is India's leading neurology educational YouTube channel, and also subscribe to my FB page, Dr. Sreenivas Concepts. Thank you.